Welcome to Rafacor, your trusted source for medical learning and healthcare awareness. If this video helps you, please like, share, and comment your thoughts. And subscribe to Rafacor for more medical education and updates every week. Alright, let's go into the video.
Welcome to this explainer. Okay, so today we are not just looking at some dry, boring hospital checklist or a list of rules. We are looking at the front lines of a high-stakes, invisible war. Every single day, healthcare workers step onto a battlefield where the enemy is entirely microscopic, highly contagious, and remarkably resilient. So how do they survive? How do they actually keep us safe? Well, they use a deeply systematic approach to infection control and a very, very specific suit of protective armor. Listen, standard hand washing and basic hygiene, they're fantastic. But when we're dealing with the heavy hitters, those highly communicable pathogens, routine practices simply aren't enough. These microbes are absolute experts at finding ways to jump from person to person. And that is exactly why these advanced defensive measures, what we call transmission-based precautions, are so absolutely critical. They're the tactical response when routine just won't cut it. Here's a quick roadmap of what we'll cover today. We'll start with the 3 isolation zones, then manage specific disease threats and break down the PPE arsenal. After that, we'll look at masks and eye protection, navigate medical gloves, and walk through the proper ways of donning and doffing. All right, Section 1, the 3 isolation zones, setting the boundaries of engagement. So, the crucial concept to grasp right off the bat is transmission-based precautions. This is definitely not a one-size-fits-all strategy. It's a combo of standard safety measures plus additional, highly specific protocols categorized into 3 main zones: contact, droplet, and airborne. The goal here is a total paradigm shift. We are trying to isolate the infection, not necessarily isolate the patient. The physics of these 3 zones are actually really fascinating. For contact precautions, distance is everything, keeping beds at least 1 meter apart and covering infected sites. Then you have droplet precautions, which deal with heavier secretions that fall to the ground pretty quickly, usually within 1 to 2 meters. A standard mask does the trick there. But airborne, that's where it gets wild. We're talking about dried particles smaller than 5 micrometers. They literally float, so you need a specialized airborne infection isolation room with negative pressure and more than 12 complete air changes every single hour just to clear that invisible threat from the room. Moving on to Section 2, managing specific disease threats, identifying the adversaries. You see, different adversaries demand entirely different tactical responses. For droplet spreaders, think meningococcal disease or pertussis, it's all about rapid diagnosis and getting a mask on the healthcare worker immediately. Rabies, which you usually get from dog or bat bites, actually just requires standard precautions, but it heavily relies on post-exposure prophylaxis if someone is exposed. Meanwhile, airborne pathogens like measles are so highly infectious that susceptible healthcare workers, those without immunity, must be strictly restricted from even setting foot inside the room. No exceptions. Okay, Section 3, the PPE arsenal breakdown, building the physical barrier. According to occupational safety standards, personal protective equipment, or PPE, is specialized clothing worn for protection against infectious materials. The core arsenal is broken down into 4 distinct categories. We've got gloves, gowns and aprons, masks and respirators, and protective eyewear. Let's look a bit closer at how these individual pieces actually work together. Let's kick things off with the gown. Proper technique for an isolation gown is absolutely vital. This single-use, fluid-resistant garment forms the largest surface area barrier between the healthcare worker and potential blood or bodily fluids. It is quite literally the main shield for the body. But wearing this shield comes with some strict rules. You have to fasten it securely at the neck and waist and ensure the gloves are pulled over the cuffs to create a tight seal. But here is the critical part. You remove it by slowly rolling it inside out. Why? Because the outside is now a highly contaminated zone. Improper removal is exactly when a worker is most vulnerable to accidentally exposing themselves to the very pathogens they just blocked. And for sure, never reuse a disposable gown or wear it wandering down the hall. Which brings us to Section 4, masks and eye protection, guarding the respiratory tract. Now, there's a super common misconception that a procedure mask and an N95 respirator are the same thing. They're not. A standard procedure mask is loose-fitting. It's great for stopping large infectious fluid droplets and splashes from hitting your mouth or nose. But an N95, that is heavy duty. It's tight-fitting, inherently more difficult to breathe through, and it specifically filters out floating particulate matter down to an astonishing zero point 0.3 microns. That is microscopic armor. But here's the catch. An N95 is completely useless without a perfect seal. You have to mold the metal strip right over your nose. You have to place the top strap high on the crown of your head and the bottom strap at the base of your neck. Then you actually have to perform both a positive and negative pressure seal check with your hands to make sure absolutely zero air is leaking out the sides. Rounding out the facial armor is eye protection, your goggles, safety glasses, or face shields. They have to be adjustable and allow peripheral vision so the worker can actually, do their job. But notice the sequencing here. Eye protection goes on after the gown and mask, but before the gloves. And when you take it off, you must use clean, ungloved hands to touch only the earpieces or headbands behind your head, because the front of that shield is considered totally contaminated. Section 5. Navigating medical gloves, the first line of contact. So, the World Health Organization actually has a glove pyramid that dictates exactly what type of glove to wear based on the risk level. For the highest risk stuff, like surgery, you use sterile gloves. For medium risk, like contact with blood, standard examination gloves are the way to go. But get this, the crucial point at the bottom is that sometimes gloves are absolutely not indicated. If a worker is just taking a blood pressure reading, giving oral meds, or moving furniture, wearing gloves isn't necessary. In fact, it can actually create a false sense of security that leads to cross-contamination. Hand hygiene is the priority there. But when gloves are required, even standard non-sterile ones have a highly specific donning technique. You take one glove from the box, touching only a restricted surface at the top edge of the wrist cuff. You slide your hand in, then use that gloved hand to carefully extract the second one. You are actively trying to minimize how much your bare hands touch the outside of the glove box or the exterior of the gloves themselves. Finally, Section 6. Proper donning and doffing, the high-stakes ritual. Putting on the armor, what we call donning, has to happen in an exact 4-step sequence. Gown, first, then the mask or respirator is fitted, then the goggles or face shield, finally the gloves go on last. Why the specific order? Well, this precise sequence ensures that all those overlapping physical seals lock into place perfectly, with the gloves capping off the gown sleeves to create one unbroken barrier. Now, if we are talking about sterile procedures, the donning ritual becomes intensely focused. You are only allowed to touch the folded inner cuff of the first glove. Once one hand is gloved, you slide your sterile fingers under the fold of the second glove. If you accidentally brush the outside of the sterile glove with your bare skin, you've instantly ruined the asepsis. You literally have to throw them away and start entirely over. And, finally, taking the armor off, doffing. This is arguably the most dangerous part of a healthcare worker's shift. You pinch one glove at the wrist, ensuring you don't touch your own skin. You peel it away, turning it inside out, and hold it in your other hand. Then you slide your clean, ungloved fingers under the wrist of the remaining glove, peeling it down so it rolls over the first one. You have essentially created a little biohazard package, trapping the pathogens on the inside. You discard it and you immediately wash your hands. It takes slow, sheer precision. Which leads me to this final question I want to leave you with. Think about doing all of this, the tight N95 seals, the specific sequence of doffing, the sterile pinching techniques, at hour 10 of an exhausting, chaotic hospital shift. Could you maintain that rigorous mental discipline flawlessly every single time? Because that is the immense, invisible mental load healthcare workers carry every single day to wage this war and keep us all safe. Thanks so much for joining me on this explainer. I really hope it gave you a whole new appreciation